Our first talk is by Dr. Sharma, Kavita Sharma. She's a cardiologist and a lipidologist at Ohio Health. Welcome, Kavita.
Thank you. All right, good morning. It's nice to be here. So again, I am hey, Dr. Mara, long time no see. I'm a cardiologist and lipid specialist at Ohio Health. I'm going to be speaking to you today about the future of lipid-lowering therapies. So these are my disclosures. So what I want to focus on is a recent expert consensus decision pathway that was published by the American College of Cardiology, American Heart Association, and National Lipid Association. It is served as an addition to the 2018 blood cholesterol guidelines from the ACC, AHA, and NLA. What it's looking at is the role of non-statin therapies for LDL lowering in the management of atherosclerotic cardiovascular disease risk. And why was this published? Well, there's been really an explosion in medications over the past few years. And this guideline served as guidance on how we should be using these medications in practice. So stepping back, when we talk about these newer agents, I wanted to just give a brief kind of reminder on transcription and translation. So, the way that proteins are generated in the body is DNA is transcribed to RNA, and then from RNA it's translated into proteins, and proteins then create a phenotype. And these medications, some of these new ones, they act on this pathway in ways that we've never really seen before. So there's siRNAs, or short interfering RNAs, that prevent translation into proteins. And then there are antisense oligonucleotides, which also act to prevent protein expression and translation. So some of these newer agents act on these pathways. So the era really over these past 10 years have been really fascinating. 2015, 2016 saw FDA approval of the PCSK9 monoclonal antibodies, which are alirocumab and evolocumab, Praluent and Repatha. And then in 2020, there was FDA approval of bempedoic acid, which is an ATP citrate lyase inhibitor, acts upstream of HMG-CoA reductase in the cholesterol production pathway. And then in 2021, we've had evinacumab approved specifically for LDL lowering in homozygous FH. So this is a really fascinating medication. So it acts on ANGPTL3. And ANGPTL3 acts on lipoprotein lipase and endothelial lipase and affects triglyceride and LDL production. So much more to come yet on this pathway, ANGPTL3. But right now we do have FDA approval for homozygous FH. And then inclisiran, so another fascinating medication. So that's an siRNA against PCSK9, which really needs to be dosed infrequently and leads to substantial LDL lowering. So the PCSK9 monoclonal antibodies, evolocumab and alirocumab, reduce the LDL by an additional 60% on top of statin therapy. Inclisiran is similar in its effects, but not quite as potent. It's more of a 50% reduction, but it's dosed much infrequently. So very interesting medications. So this is the framework of the 2022 expert consensus decision pathway. And again, this is very similar to the 2018 guidelines, where you have 4 patient groups that are statin benefit groups. So you've got your secondary prevention, adults with clinical ASCVD, and then the primary prevention groups, so those with primary severe hypercholesterolemia, LDL greater than 190, adults with diabetes, and adults without diabetes. So just a quick call out to the primary prevention algorithm. This is, again, very similar to the 2018 blood cholesterol guidelines. I just want to focus on this group. So adults age 40 to 75 and LDL 70 to 189 without diabetes. So the guidelines in 2018 and this decision pathway say first thing we do is obtain the 10-year risk from the risk calculator. And then anyone that falls above 7.5% really meets a class 1 indication for some degree of statin. What is interesting about this guideline is that it does set a threshold of an LDL greater than 100 for intermediate risk patients to try to achieve, basically. And if you remain above that threshold, we could consider intensification of statin therapy. So that's one difference. It set a number or a threshold that the 2018 guidelines didn't for primary prevention. Similarly, they set a threshold of greater than 70 for the highest risk primary prevention cohort for intensification of therapy. One quick thing is that mildly elevated risk or borderline risk, what they say is if they have risk enhancers, we should be having that risk discussion of should they be on statin therapy. And those risk enhancers are things like elevated triglycerides, premature family history of coronary disease, elevated lipoprotein(a), things like preeclampsia or gestational diabetes or inflammatory disorders, but elevated CRP. But one huge one is they gave us, our entire ethnicity, is a risk enhancer. So given the elevated atherosclerotic cardiovascular disease risk. So I think that is kind of a powerful statement that I don't know how we should all be taking that, but that is something to consider when you're thinking about statin therapy. So next algorithm I want to look at is patients with ASCVD who are at very high risk. So again, this is similar to the 2018 guidelines, and we'll define very high risk in a second. But these are secondary prevention patients, so they've had a known event, and they have additional factors about them that put them at very high risk. In the 2018 guidelines, it said if you had an LDL above a threshold of 70, that we could consider intensification of therapy, addition of non-statin therapy. Well, this recommendation gives a threshold of 55. So that's a big difference. So if someone is above a threshold of 55 or a non-HDL threshold of 85 on maximally tolerated statin therapy, and of course we work on lifestyle, adherence to medications, risk factors, but the first thing you can do is add ezetimibe or a PCSK9 monoclonal antibody. And a second option is to add a bempedoic acid or inclisiran. So difference here again is that threshold of 55, and this time around, it's a first option to do ezetimibe or a PCSK9 inhibitor, actually, or a PCSK9 monoclonal antibody, Inhibitor is not what they're calling it anymore because of inclisiran. It's also an inhibitor. So evolocumab and alirocumab are now called PCSK9 monoclonal antibodies. So in the 2018 guidelines, we are supposed to add ezetimibe and then a secondary option as a PCSK9 monoclonal antibody, but now we can go straight to that if you're above that threshold of 55, your ASCVD history, and very high risk. A secondary option is bempedoic acid or inclisiran. So why is, first of all, let's define very high risk. And these are actually patients that are very commonly seen. So these are people who either have two of these, two major ASCVD events, so recent ACS, history of MI, history of stroke, symptomatic peripheral arterial disease, or one of these and multiple high-risk conditions. So age, heterozygous FH, history of prior coronary event, diabetes, hypertension, CKD, smoking, persistently high LDL, or history of heart failure. So very high risk is actually not that difficult to find. So why do these recommendations identify these medications? So again, the first thing that you can do if the threshold's above 55 is add either ezetimibe or a PCSK9 monoclonal antibody. Well, ezetimibe is in here because of Improve It. So Improve It was a cardiovascular outcomes study that showed that ezetimibe added to statin therapy after acute coronary syndrome resulted in reduction in the primary endpoint, composite cardiovascular death, non-fatal MI, unstable angina with rehospitalization, coronary revascularization, or non-fatal CVA. So that was after a median follow-up of 6 years. And then why are the PCSK9 monoclonal antibodies listed? Well, they also have cardiovascular outcome data. Alirocumab and evolocumab, the two PCSK9 monoclonal antibodies, they reduced the LDL by approximately 60%. Alirocumab was shown to have a 15% relative risk reduction in the primary endpoint of cardiovascular outcomes, composite of death from coronary heart disease, non-fatal MI, fatal or non-fatal ischemic stroke, unstable angina requiring hospitalization. And this is in the post-ACS population. And then evolocumab was similarly shown in the Fourier trial. So this was 27,000 patients with ASCVD, LDL greater than 70 on a statin, randomized to evolocumab or placebo. And you saw an LDL reduction of close to 60%, and then a 15% relative risk reduction in the primary cardiovascular outcome endpoint, and a 20% relative risk reduction in the secondary endpoint. So that's why it has made it to the recommendations as class 1 indications for LDL above that threshold of 55, very high risk ASCVD patients. Why do they talk about bempedoic acid and inclisiran? Well, these are the studies that support that. So there is a whole series of studies, the CLEAR studies, looking at bempedoic acid, and this is one of them, which is CLEAR Serenity, and it shows the addition of bempedoic acid versus placebo in patients with hyperlipidemia and statin intolerance resulted in a 21% reduction in LDL cholesterol. Now, the cardiovascular outcome trial is still ongoing, so we don't have outcome data yet, but we do see LDL lowering. Inclisiran, and again, this is just fascinating what it can do. So it is a siRNA agent. It is focused to hepatic uptake, directs the catalytic breakdown of messenger RNA for PCSK9. It's been FDA approved for heterozygous FH and secondary prevention of ASCVD. This was just this past December. And the Orion trials are the trials looking at that. And we can see here in the Orion trials that you've got close to 50% reduction in LDL with it. And its dosing strategy is just very amazing. So you give it on day 1 and then day 90, then every 6 months after that. So PCSK9 monoclonal antibodies, evolocumab and alirocumab, you give twice a month, sub-Q injection. This is ultimately twice a year. So it's amazing. Right now, it doesn't have outcome data. So that's the holdup. There's 2 outcome trials in the works that are several years away from completion. So it's really interesting. The implications of it, if you start thinking about it, are pretty amazing. So another part of the pathway is looking at FH. And so this is another algorithm. So these are now patients who have ASCVD, who are very high risk, and whose baseline LDL is greater than 190, with belief that it's FH, or familial hypercholesterolemia. And what's interesting about this is that it's similarly set at a threshold now of 55 for LDL, or non-HDL of 85 to intensify therapy. So that's also a difference from what the 2018 blood cholesterol guidelines said. So I just have in my head now these very high-risk people we should be looking at their LDL of greater than 55. What they say here is the first thing we can do is consider ezetimibe and/or PCSK9 monoclonal antibody, or second, we could do bempedoic acid or inclisiran. And then third, we could consider evinacumab, lomidopide, and/or LDL apheresis. Now, lomidopide and LDL apheresis have been around for a long time for LDL lowering in homozygote FH patients, but evinacumab is a new medication. So let's briefly define familial hypercholesterolemia, or FH. So FH is an autosomal dominant genetic disease present in all racial and ethnic groups. It's a cause of premature ASCVD. In the pre-statin era, the median age of onset for first MI was about 50 in men and 60 in women. It actually has the highest prevalence of genetic defects that cause premature mortality at 1 to 200 to 1 to 500. There's 3 major genetic defects that lead to it, either in the LDL receptor or defects in ApoB binding to the LDL receptor, or gain of function in PCSK9 enhancing LDL receptor degradation. It leads to those elevated LDL levels of greater than 160 in children and 190 in adults. What happens is that cumulative lifetime exposure of LDL, basically leads to that premature atherosclerosis. So patients with FH see by age 35 what patients without FH see at age 55. And so that premature exposure leads to the premature events. And unfortunately, it's undertreated and underdiagnosed, with less than 1% being diagnosed in most countries. So this is the diagnostic criteria that have been published, and it follows along what we just talked about. So if your LDL as a child is greater than 160, or as an adult greater than 190, and that premature coronary disease history in a first-degree relative, who's similarly affected, or positive genetic testing. So all those things are things to look at when we're diagnosing it. And then homozygote FH has higher LDL, so LDL greater than 400. And those people, unfortunately, start having events in their 20s. One thing to think about is many homozygote FH patients are actually compound heterozygotes, where they have 2 different abnormal alleles leading to FH. But again, management is getting that cholesterol down. So why is evinacumab so interesting? Well, evinacumab, again, is an ANGPTL3 inhibitor, monoclonal antibody against it. And it in this trial, so this is 65 patients with homozygote FH on stable lipid-lowering therapy, baseline LDL 255, randomized to evinacumab or placebo. They had an additional reduction in LDL 47%. So this is on top of everything else that we can give. So it's interesting, and it'll be interesting to see where everything goes. So right now, so we talked about it's a human monoclonal antibody to ANGPTL3. It results in decreased triglycerides, LDL. It actually does lower the HDL as well. It's FDA approved for homozygous FH, approved February 2022. And then we just talked about that trial, the ELLIPSE trial, where you had a reduction in LDL 47%. It is administered IV every 4 weeks, and these are kind of its common side effects, so something new on the block. Now, evinacumab, or ANGPTL3 inhibitors, also lower triglycerides, and there's a lot of interest in this as well. It is not FDA approved for triglyceride lowering, but we see its impact on it. Unfortunately, the phase 3 trial is never going to happen, for triglyceride lowering in evinacumab. They didn't, they stopped it. But there are other ANGPTL3 inhibitor trials in the works. So there's more to come on this molecule, basically. So I know we started a little late, so should I go a little late too? Okay. So I just want to next talk about lipoprotein little a. So lipoprotein little a elevated levels of it are another inherited problem that leads to premature risk for heart attack and stroke. So it is comprised of the LDL-like particle and apolipoprotein A attached to ApoB via a disulfide bridge. Meta-analyses have shown that elevated Lp(a) levels confirm high risk of MI, ischemic stroke, aortic valve stenosis, coronary artery stenosis, heart failure, cardiovascular mortality, and all-cause mortality. And an Lp(a) level greater than 50 milligrams per deciliter or greater than 100 nanomoles per liter may be considered as a risk-enhancing factor favoring the initiation of statin therapy. And this level corresponds to the 80th percentile in populations which are predominantly Caucasian. So we know it to be a risk factor. We don't really know why it leads to that increased risk. But what's also interesting is there are emerging Lp(a) therapies. So there is an antisense oligonucleotide, pelacarsen, which has resulted in very significant reductions in Lp(a). And this is not outcome data yet, though. So there's an outcome trial in the works, but we can see that we have a large reduction in Lp(a) with its use. There's a second Lp(a) therapy in clinical trials, siRNA olpasiran, which similarly results in Lp(a) reductions of 71 to 97%. So again, pelacarsen is not FDA approved. It's an ASO to Lp(a), and then it's phase 2b clinical trials. We can see that significant Lp(a) reduction. Its outcome trial is the Horizon trial, which is finished enrollment. So it's still got a couple of years left till it's finished, and that will that's something to watch for. Does it lower cardiovascular events? That could be the next big thing that we talk about. It is testing 80 milligrams a month sub-Q injection. The Horizon trial is. So there are other phase 3 medications out there. So ApoC3 also affects LPL levels. And LPL is important on the triglyceride pathway. So if you inhibit ApoC3, you lower triglycerides. And there are multiple trials now impacting ApoC3. So we've got the Arrowhead ApoC3 trials are really interesting. We're hoping at Ohio Health to get into some of these, so we're always talking about it. And then olezarsen is another, it impacts ApoC3 as well. So those are in phase 3 trials for severe hypertriglyceridemia. And the last one there, obicetrapib, is a CETP inhibitor. And the CETP inhibitors have a fairly long history of not working, but this is one that may work. So it's still in trials. There's multiple other therapies in the works too. There's an oral PCSK9 inhibitor peptide that could be really interesting. They're working on gene therapy against PCSK9. Again, that long-lasting impact on PCSK9 potentially. Then olpasiran is that Lp(a) siRNA. And there's also another anti-PCSK9 monoclonal antibody in the works. So that is just a quick look at the landscape. And I've been lucky to be doing lipids for now 10 years since I was at Ohio State and now at Ohio Health. And it's just been really interesting and a lot more to come. So thank you for having me.
Thank you.
Thank you.